fact. And you know what students were writing? There's a difference between diabetes. What will it be the same?
No, please.
So if I say give me risk factors for diabetes, what could be? What to be risk factors for diabetes?
Family history.
Family history. Mm-hmm. So can you say family history is a risk factor for DKA?
No, please.
No, please. And you were writing this. I am begging you, please. The questions will appear cheap. Those questions are appear cheap. Be careful about the way you answer. And some of you write too much. You write too much. Just gets to the point. Gets to the point. The question was asking about. So I was just giving marks, looking at it again. Spirit. So have you seen that this is different from gender? Most of them were writing the same question. We had about last year, we had causes of ascites. What are the causes of a fluid buildup in the peritoneum? What are the causes of fluid buildup in the peritoneum? So let's talk about the causes. The causes of what? Fluid buildup in. So the number one is what? Portal hypertension. Portal hypertension. Matthias.
Hello, sir.
How far?
Please wait. The board, Dr. Attakorah, please. When you go to the activities,
yes,
and please, when you scroll down, you should see whiteboarding.
Good. Mm-hmm. So start a new whiteboard.
Yes, please.
Okay. So can you see?
Yes, please.
Yes, sir.
Good. So we are talking about ascites. Ascites. No, that's we have for liver, which is disease here, and this is bringing content to this. So the portal vein is carrying the content of the DNA to the liver, and we have covering here. We have a covering, which is a peritoneum. So what is happening is that if the liver is impaired, the contents cannot be accepted by the liver. The contents cannot be accepted by the liver. Therefore, there will be a backflow that will build up a pressure within this. And this pressure will force, listen, and this pressure will go back into the vessels. We have what we call splenic vessels around this. And these splenic vessels discharge their content into where? Into the portal vein. So when there's now a backflow where would the content go? Please, do you get me? The splenic vessels along the GI will discharge their content into the portal vein. So, assuming you have these vessels here, and they are discharging their contents here, if there's a liver disease and there's a backflow, these contents will come back to where? The splenic vessels. Please, do you get it?
Yes. Yes.
And because the splenic vessels are smaller vessels, what will happen is that the first thing that the splenic vessels is that when they are getting these, now the pressure is above 12, and this pressure is getting into the smaller splenic vessels. So what will be? Who can tell me the first thing that will happen when these content is getting back into the splenic vessels? Who can tell me what will be the first thing that will happen to the splenic vessels? Plus, you get me.
Yes, please.
What will be the first thing now? Smaller vessels that would absorb the content of the GI. And these smaller vessels will drain their content into the vein, portal vein. It will get into the liver. Now the liver is impaired. So it's not able to accept it. Then these content will try to come back. That will put up a pressure within this, increasing the portal pressure. So it will get back to where? To the splenic vessels. What will happen to the splenic vessels?
Please, I think your vessel dilate.
The first thing is that it will dilate. So when it's causing vasodilatation, what will happen is the fluid will seep through. Do you get it? The pores will be increased, and therefore the fluid in there will seep through to get into where? To get into the peritoneum. So the portal hypertension will build up within the splenic vessels. And this will cause a vasodilatation. And when it does cause vasodilatation, the fluid will seep through and get into the peritoneum. So this is one way by which ascites could form. Please, do you get it?
Yes, please, sir.
Is it clear to, especially those who are saying they were not taught, they were taught in biochemistry?
Yes, please, you are getting it.
Okay, so the number one cause is the portal hypertension. What again could cause the portal? What again?
The activation of the RAS system.
So why the activation of the RAS system? You are right, but why the activation of the RAS system?
So please, the liver is responsible for the clearing of the aldosterone, but in liver impaired patient, there's accumulation of the aldosterone that would lead to sodium and water retention,
Mm-hmm.
leading to the ascites.
So good. We said when we were learning about the function, did we touch on that?
Yes, sir.
We said that the liver is responsible for clearing what? Aldosterone. The liver is what will happen is that there will be a buildup, and this aldosterone will cause sodium and water retention. And some of the buildup of some of the sodium and water buildup will find their way into where? And the last one is what?
Decreased serum albumin.
So the albumin.
Yes, please.
Because of all the time, there should be a balance between intracellular and extracellular oncotic pressure. There should be that balance. Now, the extracellular is having low albumin, means there's low oncotic pressure, and that should be a balance. And there will be a shift of fluid to make sure that there's a balance. And that shift will cause some of the fluid into the peritoneum. So last year they had this question just to talk about the causes of ascites. Causes of ascites. So this is three ways by which ascites could form. There's reduction in albumin. This will lead to reduction in oncotic pressure. The next thing is the portal hypertension. The last one is this. The oncotic pressure due to low albumin. We have the RAS activation leading to more production of what? More production of aldosterone. So all these three mechanisms could cause ascites. So when you are asked, it could come in oral, it could come in a theory. Last year they had this question. So portal hypertension, reduction in serum albumin, and we talk about the RAS, activation of the RAS, and the buildup of, and this will lead to the buildup of aldosterone. These are three mechanisms by which ascites could be formed. Please, is it clear?
Yes, please. Yes, please.
So let's do something here. I want us to learn something here. Patient comes with ascites. I want us to learn a lot from here. Patient coming with ascites. We can tap the acidic fluid and do a lot of investigation on acidic fluid and come out with a lot of things. So diagnostic aspiration of acidic fluid can take about 10 to 20 could be achieved when you perform these analysis on aspirated fluid or acidic fluid being tapped. What are the things that could be obtained? If I'm asking you a question like, what are some of the parameters that could be derived from acidic fluid being analyzed? What could be your answer? If you do analysis of those acidic fluid, patient who having ascites, you tap. You can do analysis on the acidic fluid. What are some of the things that could be obtained from the analysis?
Certainly the neutrophil count.
So the cell count, good. Note this, very important. The neutrophil count. And the neutrophil count will point to what?
The presence of bacterial peritonitis.
So So when the neutrophil count is above 250 cells per mm cube, millimeter cube, then it means that the fluid is becoming infected. The type of infection is called spontaneous bacterial peritonitis. Spontaneous bacterial peritonitis. The cell count. When the cell count is above 250 cells per millimeter cube, and is indicative of spontaneous bacterial peritonitis. Please, do you get it?
Yes, please.
What again could be done? What again can be obtained from the analysis? What again?
Dr. Attakorah, please,
What?
proteins.
Proteins. Good. We can obtain proteins from it. So when you see proteins in it, what is protein helping you to achieve? We can check the protein levels in the ascites. Please, very important. You can check the protein levels. When you are checking the protein level, what is the essence of checking the protein levels? It's helping you to achieve what?
To determine if it is native or
Okay. Come again.
and
Come
with the
again.
would help you to know if it's transudative or exudative ascites.
So the proton levels will help you to distinguish the type of ascites that the patient is experiencing. So it's important to know the protein levels. Analysis could help us find the protein levels. And when you know the protein level, it can help you to differentiate and tell us the type of ascites that the patient is having. Could be exudative or transudative. We can differentiate this based upon the protein levels. So now,
Please, exudative or
transudative and exudative. Do you get it?
yes, please.
So transudative. What will point to the fact that it's transudative? So these are some of the characteristics that you need to know. When you see these characteristics, then you see that this ascites is transudative. Note this. So transudative ascites is all the time due to increase in portal pressure. It's always due to increase in portal pressure or portal hypertension. And all the time, the portal hypertension is greater than 8. And patient will be experiencing the transudative when the pressure gets to 20. So high pressure means that the pressure is above 8. Note this. High pressure means that the pressure is above what? 8. because the normal is 5 to 8. So when the pressure is above 8, then we see that the patient is getting what? Getting increase in what? Portal pressure. And when this increase in portal pressure is giving us ascites, then the type of ascites is termed as what? Transudative. First characteristics that you need to know. And for transudative ascites, there's always low, they have low proteins. You'll be seeing low proteins in acetic fluid, which is, it will be less than 30 grams per liter, less than 30 grams per liter. Transudative will come with low protein levels in acetic fluid. It will be due to high portal pressure, which is above 80. And there's low, this is what you'll be seeing. And take note of these small things. And low proteins, which is less than 30 grams per liter. There's low LDH. Low LDH. Learning which conditions could cause low proteins. There'll be normal glucose. There'll be high pH, and there'll be low LDH. Is not due to the high pressure built up within the portal vein. Cancer or inflammation, that will give you exudative. And for exudative, the characteristics for exudative, you can say is the opposite. Exudative can have high protein level. High protein level can have high LDH, low pH, low glucose level. And talking about WBC, there'll be more WBC. Please, is it clear? Is it clear, class? Can you hear me? If I ask you to differentiate between transudative and exudative ascites, can you do that for me?
Yes, please.
You can do that.
Sir, please kindly go over the exudative parameters again.
I'm saying it's the opposite. If I'm saying it's the opposite, what does it mean?
Oh, okay, sorry. Then it means it's high in protein.
So high in protein, high in LDH, low pH, more WBC, low glucose level. This is just the opposite. Plus, you get it.
Yes, please.
So, any other parameter that could be obtained from the analysis. If I ask you, what are the things that could be obtained from analysis of acetic fluid? We have talked about cell count. we have talked about protein levels, and the protein levels could give us this transudative and exudative ascites. What again? Depending on the protein levels, can tell us transudative, we having low protein level, exudative, high protein level. In other things, transudative, it's mainly due to increase in portal pressure. Exudative is due to inflammation or malignancies. So exams and MCQs, because of MCQs, you should know these small things. What again? Which parameter can we get from this?
We can also get the serum acidic albumin gradient.
And also get what?
Serum acidic albumin gradient.
And also obtain serum acidic albumin gradient. And you call it what? Serum albumin. Serum acidic albumin gradient. So what is the formula? Because SAAG, such. What is the formula? For this serum, can also obtain serum acidic albumin gradient. Good. SAAG. What is the formula for the SAAG? What is the formula, class? So the formula for serum acidic albumin gradient.
Serum albumin minus acidic fluid albumin.
So serum albumin. You said that serum albumin and what?
Minus the acidic albumin.
Serum albumin minus acetic albumin. Is that what you say?
Yes, please.
So this is a simple equation. So serum albumin minus acetic what? Is that acetic or what? Is what? The formula is what?
Serum albumin level minus the acidic fluid albumin level.
Okay, so it's a simple equation. So this is SA is equal to serum albumin minus acetic what? Albumin. So what is the importance of this equation? Serum albumin minus acetic albumin. Albumin found in the serum and albumin found in the acetic fluid. What is the essence of knowing this? These, when you compute this, it can give the formula can give you 1.1. Either you get a value greater than or equal to 1.1, or you get less than 1.1. So what is the clinical importance of this? The SAH, the search. What is the clinical importance of this, knowing this simple formula.
To know whether
Please, I think it's whether the ascites is exudative or transitive, in that it is happening as a result of increase in the portal vein pressure on it.
So you computed this simple way. Then you had a value greater or equal to 1.1. That 1.1 becomes a standard, 1.1. If you get a value greater than 1.1, what does it mean?
portal
So it means it's what? It's portal hypertension. So note this, when the surge SAA which is equal to serum albumin acetic albumin, when it's greater or equal to 1.1, and it means that the cause is as a result of what? Portal hypertension. When it's less than or equal to 1.1, what does it mean?
probably
Due to what?
an infection or magnet.
So could be due to infection or inflammation. This formula can also help us to know some of the causes. The acidic fluid. It's helping us to establish. So these values could also help us to know other causes of the buildup of fluid within the peritoneum. Other causes. So if it's greater than 1.1 or equal to greater or equal to 1.1, then you could have other causes like hypoalbuminemia could be. It could be heart failure, it could be cirrhosis, and it could be alcoholic hepatitis. Other causes. So if a patient comes with heart failure, heart failure can lead to what type? If I'm asking, heart failure can lead to what type of ascites? So I can bring a question here that a heart failure patient comes with surge of greater or equal to 1.1. If I ask what type of ascites is the patient developing, what would be your answer? It will be what? Transitive. So please note these things. Is it clear? The whole class, is it clear?
Yes, please.
If you don't understand, let me know. Because the reason why I'm afraid of this, your professional exam system, anything can come. Anything. So when you are learning, it makes it, when you rush in your learning, is also another problem. A question will come and you feel like, let him do shade with it. So these things. So when you check and the value is less than 1.1, we say could be due to what are some other causes, other conditions that could give you less than that. Less or equal.
Lymphatic syndrome.
We are talking about inflammation, we are talking about infection. Put this at the back, inflammation. So you can talk about pancreatitis. You can develop SBP. So what will be the most likely with the surge of less than 1.1? Patient with ascites, the surge of less than 1.1. What will be the most likely type of what? Ascite. And you should know that it will be what?
Exudative.
To be exudative.
Yes.
Okay, what parameter can also be obtained from the analysis? So let me ask you this. So if I found the analysis, if I find this enzyme, I don't know whether you have you gotten what I'm teaching you?
Yes, sir.
Yes, sir.
Uh-huh. So if I found this enzyme, what is the name of this enzyme? What is the name of this enzyme?
Amylase.
So if I find this enzyme in the acidic fluid, what would you say?
Sir, please, it is an indicative of pancreatic ascites.
What condition would you suspect that the patient will be having?
The pancreas.
So it's indicative of pancreatic ascites. So it's indicative of pancreatic what? Ascites. It's indicative. So when the moment they check for these enzyme amylase, then they want to rule out what? Pancreatic ascites. So when a patient comes to pancreatitis condition, the patient can develop what? Ascites. So when you check and the enzyme is not there, it means that we have excluded what? Pancreatic condition. Any other thing that could be obtained could be obtained from the investigation. Can't you also do cytology? Can you also do cytology on the fluid, the tapped fluid?
Yes, please. It should be done.
You can do cytology, and when you are doing cytology on the fluid, what are we looking at?
For malignant cells.
So for malignant cells. So note this. If you are asked, what can you obtain from the acidic analysis? we are tapping acetic fluid. What are the things that we can obtain from it? We can do cytology. We can exclude pancreatic ascites by looking at amylates. We can also check the protein levels to also enable us know whether it's exudative or transudative. The last one could be what? Who can tell me?
Gram stain.
And also do gram stain. And that gram stain will help us. Will help us do it.
Identify for bacteria infection.
Bacteria and what? And what?
Acid fast bacilli.
Acid fast bacilli. So you can also do gram stain and culture for bacteria and acid fast bacilli. When I'm looking for acid fast bacilli, then what am I looking for?
Tuberculosis.
Tuberculosis. Tuberculosis. Tuberculosis. So any question so far what we have done?
So please, is it appropriate to say that gram stain is to rule out extrapulmonary TB?
To rule out extra
Pulmonary TB.
Why are you specific saying that? There is extra pulmonary. It could be. Don't you know that some of these organisms can also get in there? So
Okay.
to be the safer side, just for TB. Do you get it?
Yes, sir.
Don't commit yourself. To be on the safer side, say TB, and you go your way.
Yes, sir. Thank you.
Okay, so management, ascites. Management. How do you manage ascites? So, a question. This question was okay. Management of ascites. How do you manage ascites? Who can tell me? If we talk about managing, how do you go about it? At times, let me warn you guys, at times you know. I keep on asking you more questions. I want to know the way you answer questions.
His use of diuretics or diuretics.
I'm coming. I want to know the way you would answer the questions. It's just that I'm not doing face to face with you. I'm asking a lot of questions. And that question means that I want to know the way you answer questions. I'm talking about listening. I'm talking about how do you manage ascites. I want to know the way you tackle this. And this is the way. The question will look so cheap, but you'll be getting low marks. So how do you manage it? Ascites.
Hello.
Hello.
I think that you have to look at it from 2 points of view.
Mm-hmm.
So the first one, you have to look at the acute management of the ascites. And then the second part, you also look at the, what do you call it? The acute side, that is where you talk about, you do the paracentesis and all those stuff, where you replace with the albumin and all those things that you've tapped. Then you come and look at the I've forgotten the word. The chronic management. The chronic management, yeah. That's where you do the diuresis and others.
So yours is talking about acute.
Yeah, two phases. You first talk about acute and then you talk about the chronic management.
So any other, how do you, if I say, how do you manage aside? Simple question.
You first talk about the non-pharmacological before you come to the pharmacological.
So the first speaker, note this. It's very important. When you are asked about that, look at non-pharmacological and what? Pharmacological. I will come back to what you said in acute management. I'll come back to that. So you first look at the non-pharmacological and what? Pharmacological. So non-pharmacological, how do you manage ascites? These small things. Hey, the question will look cheap, but please. So non-pharmacologically, how do you manage this?
Adequate rest.
So rest, bed rest. Bed rest will lead to diuresis in a smaller proportion. Bed rest. What again?
Reduction
Sodium.
water intake to less than to around 1.5 liters per day.
Come again.
Reduction of water intake.
Talking about restriction of water.
You also talk about sodium restriction.
So dietary sodium restriction. So use the word dietary. Sodium restriction. So these are non-pharmacological management. And please take note of these small things. So pharmacology, do you manage ascites?
So that is where I talk about the acute side, the acute management.
I'll come to it. I'll come to the acute. I'll come to the acute, don't worry. But I want you to step. At times you have the knowledge, but the way to approach the question is one thing. I'll come to that. I'll tell you the way to go about the acute. How do you manage ascites? So look at non-pharmacologically and what? Pharmacological. How do you manage it? What is the first line? Hurry up. First choice. How do you manage it? So acute person. So if I say acute, how will you manage it? The one who is saying acute. How do you manage it? If it's acute.
So that is where if there is the need to do paracentesis. That's where if there's a need for you to do paracentesis, you do the tapping, and then you follow with the replacement of the albumin. If it's above 5 liters, you then have to do some albumin replacement.
So how do you classify your acute? How do you see that the patient? That's why I say I will come to that. How do you see that this is acute?
So you look at the if there's abdominal distension, there's edema, where you do the SAG analysis to see if it is transudate, which is greater than 1.1. It means it's coming from the portal hypertension. So there's a need for you to do some tapping.
So please listen. Be careful about the way you answer question. Be careful. It's so cheap. I'm giving you the steps. Stop your acute. I'll come to where you are saying is acute. Do you get it? I will come back to the point that you are saying is acute. We don't start by saying this. The first step is non-pharmacological. You tell the patient to restrict diet, to rest. Pharmacologically, and there are 3 stages. The first stage is non-pharmacological. Second stage is what? The pharmacological. I'm asking you, pharmacological, how do you manage ascites? And you're thinking about and it's acute. I'll come back to the acute. And you cannot, the reasons that you are giving to tell me is acute are not the reasons that will let you pass for this question. And I will tell you the reasons. Finished with the pharmacological, then I'll get to the stage where you're thinking is acute.
So please, for the pharmacological, you can consider the aldosterone antagonists such as spironolactone.
So you consider, that is the first choice, diuretics. You consider aldosterone antagonist. Why do you consider aldosterone antagonist? That's the first choice. Why do you consider? Why the patient's stomach is big, full of fluids. Why do you consider? Why don't you consider legs first? Then you consider aldosterone antagonist as a first choice.
Because high aldosterone levels as a result of RAS activation is a cause of ascites.
What is causing? Give me two processes that is causing aldosterone accumulation in this patient, elevation of aldosterone in this patient. 2 processes that will cause aldosterone in this patient.
Okay, so the first process is because of the liver impairment, in which there is a decrease in the metabolism of the aldosterone. And then the second one is the decrease in intravascular volume due to the low albumin levels. So because of the decrease in the oncotic pressure, there is low intravascular volume due to the loss of fluid into the interstitial spaces.
Mm-hmm.
So this activates the compensatory mechanism through the RAS system to cause sodium and water retention to maintain the intravascular volume.
So in simple terms, listen, in simple terms, does low perfusion to the kidneys, do you get it? There's accumulation of fluid. An accumulation of fluid reduce perfusion to the kidneys. That will activate what? The RAS. Do you get it? Plus, do you get it?
Yes.
The second point is that because the liver is responsible for clearing aldosterone, the liver is impaired. There'll be reduction in metabolism of what? Aldosterone. And that will cause also the buildup. So RAS activation and inability for the liver to metabolize that would cause elevation of what? Elevation of this. So I am saying somebody was answering this. I'm saying.
Can you say the second point?
Who can help me? What did I say?
Please, you mentioned that the liver is responsible for clearing aldosterone. So in the impairment, you consider taking out the aldosterone.
You consider what? Come again. There's a decrease. Two things. I'm saying that the buildup of fluid within the peritoneum is causing reduction of fluid to the kidneys. So ascites is reducing the plasma volume. Ascites will cause hypovolemia. Note this, because the acidic fluid, we term it as that the acidic fluid is in the third space. When you say it's in the third space, it means that it's not part of the circulatory fluid. Take note of this. We say that the acidic fluid is in the third space. It means that it's not part of the body fluid again. It's not part. And because we are taking some of the body fluid into the peritoneum, it will reduce the plasma volume, and therefore amount of blood that will get into the kidneys will be reduced. That's why I'm talking about hypoperfusion. Hypoperfusion will activate the rat, and that will lead to more production of aldosterone. And the second process I'm talking about is that if the liver were to be intact, we don't care about the amount of aldosterone that are being produced by the RAX activation. The liver would metabolize this. So because the liver is impaired, if small amount is being produced, it will lead to accumulation, because there's decrease in aldosterone metabolism due to the reduced liver metabolizing capacity. And this will increase fluid retention in the system. Is it clear, class?
Yes, please.
Good. So we are giving this to a patient. We are giving this to the patient, aldosterone antagonist, as the first choice. I was asking you, why do you consider this one as the first choice? So why don't we give legs as the first choice? Now the stomach is big, fluid is within it. Why don't you give legs as the first choice? Who can tell me?
So the ladies can hypertension further reduce.
Come again.
So the use of ladies can cause hypertension and further reduce it.
The legs can cause what?
So ladies can cause hypertension and further reduce the
Hypertension.
hypotension.
Legs can cause hypotension.
Yes. And further reduce the BP.
So why do you, I'm talking about legs, why don't you listen? Why don't you talk about what legs will do first? Do you get it? You get it? And you are jumping to say that it can cause hypotension. Who can't do it well for me?
Sure. Please, if you use Lasix, it's more likely to remove fluid from general circulation rather than the peritoneum. So that will further reduce the blood volume, leading to the hypotension.
Good. So don't jump. Don't jump. If you are answering what the legs will do, you've mentioned it. And it will lead to that. So the legs would affect the plasma volume, not the peritoneum, the volume of fluid in the peritoneum. So there will be a drastic. This will cause drastic diuresis. That will cause hypovolemia. So this shouldn't be used as a first line. We are not talking about kidney. We are talking, and I'm saying, why don't we use Lexus?
And giving Lexus to
hypokalemia. Take note of this. There's a fear of hypokalemia. There's a fear of hypokalemia. And hypokalemia in liver disease can lead to what? Especially alcoholic liver cirrhotic patient can cause what? Can cause what?
Encephalopathy.
Can cause encephalopathy. So we are afraid of hepatic encephalopathy. That is why I don't want to use Lexus as a first line. And the second point is that in this thing, find out. I'll be asking you in my next lecture. Do you know what? I'm putting emphasis on this ascites, and I'm taking my time to go through every salient point here. Lexus and low albumin. Find out how Lexus is effective when a patient comes with low albumin. You get it, class?
Yes.
You get it?
Yes, please.
Low
Please,
albumin.
can you repeat the question?
I am saying that find out this low albumin and what? And Lexus. The effectiveness of Lexus when you have hypoalbuminemia. Do you get it?
Please.
Do you get it? You now get it, the question.
Yes. Please, you have gotten it.
Good. So the effectiveness of this, of Lexus when a patient comes with low albumin. So we do the first choice directive, which is aldosterone antagonist. And we do. Come again.
Please, the question again.
Who got the question?
Please, you were asking how Lexus is effective in low albumin.
Have you gotten the question now? I said find out the effectiveness of Lexus when the patient comes with low albumin. You get it. Do you get it?
Yes, sir.
Yes, sir.
Good. Good. So the first choice will be what? Aldosterone antagonist. And for this, please mute.
Yeah, why?
Come again. Are you talking to me or